Hold on one minute. David, we good?
Yes, ready.
Thank you,
Meeting
Dave.
is being recorded.
Say he came in ready.
Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Medical and Professional Affairs Committee. Today's meeting is officially called to order. If any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for purposes of quorum and voting. For the record, Jose Pagan delegated Jackie Rowe Adams. Jackie, thank you, to be counted as a member for the purpose of quorum and voting for this meeting. I'd like to propose a motion to adopt the minutes of the MMPA committee meeting held on May 8th, 2023. Sally?
Yes.
Jackie?
Yes.
And I say yes. Next, we have an action item for consideration. Good morning, Dave. Can you please read the resolution into the record and proceed with the presentation?
So I will read the resolution authorizing New York City Health and Hospitals Corporation, also known as the System, to execute an agreement with Rapid Reliable Testing, LLC, DBA DoGo, Inc., also known as DocGo, for time-sensitive and short-term clinical and support staffing at any of a variety of emergency response alternative care sites, ERACS, during a period of an emergency response as directed by the system's president with appropriate notification of the board. The initial term shall be 3 years with 2 one-year options to renew, solely exercisable by the system. The contract shall not have a pre-established not to exceed amount. Dr. Silvestri.
Great, thank you, Dr. Allen. Thank you, Dr. Katz. So this particular presentation we're excited about. If I was to summarize it in a nutshell, it falls in line with the phrase, it's better to stay ready than to get ready, particularly with regard to the staffing or potential staffing needs at any number of alternative care sites. Alternative care sites are places that are alternates to our typical care sites, namely hospitals, health centers, skilled nursing facilities, where we care for people, generally community dwelling individuals with healthcare needs. So I'm going to pass the baton to Inga Frunis on my team. Inga is a registered nurse by training, and she's going to walk us through a little bit of the background of the presentation, as well as how we ultimately landed on the particular vendor that Dr. Allen just mentioned.
Thank you, and good morning, everyone. So, please back one slide. Thank you. So we're required by City Hall to provide clinical staffing for special medical needs shelters, which is a part of New York City's coastal storm plan. A special medical needs shelter, or SMNS, is a type of alternate care site that we are required to respond to. Currently, the plan is that there are 7 sites that host between 100 and 150 shelterees with a diverse set of staffing. So from medical doctor to nurse to a nursing support staff like a home health aide or a patient care associate. As Dave mentioned, the population is subacute, so they live independently, and that would be the characteristics of all emergency response alternate care sites. For special medical needs shelters specifically, the shelteries are referred at New York City operated hurricane evacuation shelters due to their need for assistance with something like administering their medication or maybe a Foley catheter change, something that they receive that service during like normal life, I guess, and they cannot receive that service anymore due to an emergency. Just as a note, transportation to the special medical needs shelters is coordinated through New York City Emergency Management. Similar to special medical needs shelters, we could be called upon and historically have been to fulfill emergency responses in the city with clinical staffing. And so we want to be prepared, as Dr. Silvestri mentioned. Historically, for special medical needs shelters, we've had challenges fulfilling those requirements and planning scenarios with our internal resources. So that's why we're seeking this contract, and we don't currently have a contract to augment our clinical staffing if this plan were to be activated. Next slide, please. So this contract would only be activated in the event of either New York City has a coastal storm and they activate the coastal storm plan, or in another scenario of an emergency response alternate care site opening, the contract would be activated if the president of our organization were to activate the contract at the request of City Hall, and there is an emergency declaration by the city, state, or federal government, and we would notify the board in that event. This activation of the contract would presuppose either city funding. So the city has a program called the OSEC program. It's OCEC. It's on-call emergency contracts, and they have money set aside for special medical needs shelters specifically. They have $36 million at this time allocated to that program for our agency. Or we would activate this contract if we are anticipating reimbursement through FEMA. A couple notes, right? A really important part of this contract is that the cost structure is pre-established, so we would not be subject to perhaps increasing costs because of the current environment. The cost structure was based on the title of the staff, the length of the activation, and the time to activation, so like the speed. And the vendor would be responsible for credentialing. That would not come from our internal resources. Next slide, please. So importantly, we don't anticipate any operating costs if this contract were not to be activated. Next slide. For the RFP criteria, the minimum criteria that we looked at was that the business have 5 years of experience with similar sized organizations. Their annual revenue had to exceed $5 million, and they had to have the ability to maintain compliance with FEMA guidelines and regulations. The substantive criteria that we evaluated vendors on was 25% for relevant experience and their plan for timely deployment, 20% for the diversities of titles offered. So are they able to provide us with all the staff that we may require, from physician to like a nurse practitioner, physician assistant, nurses, home health aides, nursing support, et cetera. 20% for cost and 10% for minority and women business-owned requirements. And our evaluation committee consisted of emergency management, finance, quality and safety, risk management, the Office of Patient-Centered Care, community care, ambulatory care, and MMPA. Next slide, please. So to overview our procurement timeline, on the 11th of April, we came to the CRC committee and requested to release an RFP. We were approved. And on May 2nd of this last year, meaning 2023, we posted the RFP to City Record. It was sent directly to 13 vendors. On the 15th, we held a pre-proposal conference that 16 vendors attended. On the 7th of June, we had 10 proposals submitted. On the 14th of June, the evaluation committee conducted our first round of scoring, and the top 3 firms were shortlisted. Between the 16th and the 20th, those top 3 firms presented to us, and we had a Q&A session. And on the 23rd, we selected from those top 3, and Rapid Reliable Testing, doing business as DocGo, was the highest rated proposer. DocGo proposed to subcontract 30% of their staffing to MWBE firms. They're listed here. They have met their MWBE requirements in previous contracts as well, current contracts that they have with us. Next slide, please. They have 2 contracts with us, and they have a good reputation with us. They have performed satisfactorily on their performance history evaluation. So Central Office Emergency Management is seeking approval to enter into contract with Rapid Reliable Testing, doing business as DocGo, to provide clinical staffing services at emergency response alternate care sites. As a reminder, no costs will be incurred if these services are not activated. Expenses will be covered by City Hall or FEMA if the contract is activated, and we will receive board approval from the president with appropriate notification. We will receive approval from the president with appropriate notification to the board if the contract were to be activated, and we are hoping to enter into contract by August 1st of this year. Thank you.
All right, that was a mouthful, but I guess we'll follow standard processes. Dr. Katz or Kalisha in terms of questions or any further comments about this.
Right. Questions from board members? Sally?
Very quick question. Have we ever provided staffing for a special medical needs shelter?
So the Special Medical Needs Shelter program, I believe, if I kind of rewind the tape, came out of Hurricane Irene. In Hurricane Sandy, we did staff some of these, but we used, as Inga mentioned, ambulatory care staff, and there were a lot of operational challenges, particularly if we were to end up having to evacuate one of our hospitals. Having a good swath of our staff moved into these shelters creates challenges, not just for the shelters, but also for the evacuation efforts.
Okay, thank you. Mario.
Go ahead, Jackie.
So I didn't see, how many staff do you have? I didn't see that.
Yeah, it depends. It depends. I'll let Inga get into the weeds, but it depends on the type of the staff and the size of the shelter. But you want
Yeah, so I mean, just for the special medical needs shelters as an example, one caveat is that it depends on how long they're opened. So we don't really know, even in New York City's coastal storm plan, like how long the special medical needs shelters will be open. We have staffing ratios. We want to have 24-hour coverage, right? We have to have 24-hour coverage. You see there's 7 sites. We want to have a provider designated to each site. We're considering there may be a provider that's just on call overnight and then physically present during the daytime. And then we have nursing ratios of 1 to 25 during the day and 1 to 50 at night. So in like a 3-day period that we were looking at, we'd have, I think I just looked at it, like 50 nurses, and the providers would, like 50 nursing shifts, I think. And then the more home health aides, like I think like twice that or 3 times, so like 100. But it is difficult because we don't know how long they're going to be activated, and we also don't know, like, we can plan for the acuity of the patients, but we won't really know, like, we could maybe get a shelter that ends up having a lot higher acuity than we expected, because it's very challenging to plan for. We don't know exactly like what patients are going to come and what conditions they may have and what the nature of like the hospital system might be going on, like who they can and cannot accept. So it's challenging to anticipate.
The contract is designed in a flexible manner
Exactly.
to deal with whatever that is. And
Yes.
that's why you've created the contract in this way,
Yeah.
because by definition, you can't know what it is exactly you're planning.
That's exactly correct.
I mean, a sort of useful sign of the kinds of emergencies, it came, I understand, I wasn't yet here, but Kohler came within hours of having to be completely evacuated after Superstorm Sandy because they lost electricity, and they had set a 72-hour as the longest the facility could function without electricity, and they just got the electricity back on, I think, at like 69 hours. Right, just to imagine, right, the scale that you could have of needing to care for people in an alternative setting, right? And you don't know. Now, in the Kohler thing, presumably the staffing would come with wherever they're going, but it's another sign of how you don't know what you're going to have to evacuate. You don't know what the level of severity is. You don't know whether or not the staff you have will all be able to get to where they're supposed to be, right? There are all of these, emergency type provisions, and what I think has been done well is that you've baked all those, possibilities into your proposal.
If there's one general, that's dead on, 100% accurate. If there's one general truism for the staffing, it would be that there's fewer providers needed than nurses, and in general, we anticipate probably equal or potentially even larger number of nursing aides or home health aides than even registered nurses, again, given that most of these individuals we're anticipating are dwelling in the community today, right? And they're receiving home health aid services, home care services, but really the provider presence is there mostly as an escalation resource.
Any other questions? Okay, then let's vote. Sally?
Yes.
Jackie?
Yes.
And I vote yes. And so the resolution will now go for full consideration to the board. Okay, Michelle, you're going to do your chief medical report?
I will start with a statement. As we continue our focus on health equity and continue to address unconscious or conscious bias in clinical care, we have developed the following statement on anti-racism and non-discrimination for health and hospitals. The statement reads, structural racism is an increasingly recognized national problem. New York City Health and Hospitals acknowledges that structural racism is a major barrier to equitable health care, which is the New York City Health and Hospitals' core value. In addition, New York City Health and Hospitals recognizes that structural racism, that is the way in which society fosters racial discrimination through systems of housing, education, employment, criminal justice, and other institutional practices, has been a significant factor in creating healthcare disparities seen in the United States, as evidenced among indigenous peoples and populations of color. These disparities include higher death rates, shorter lifespans, and poorer outcomes in the face of chronic diseases. Therefore, New York City Health and Hospitals reaffirms its commitment to identifying opportunities for reducing racism's impact in clinical care, education and training, professionalism, staff development, staff engagement, and in provider and staff recruitment. Additionally, New York City Health and Hospitals commits to actively promote social justice, challenge discrimination, and continuously monitor diversity and inclusion efforts. New York City Health and Hospitals aims to contribute to a healthcare landscape and workforce environment free of discrimination or bias on the basis of race, color, national origin, alienage, or citizenship status, religion, creed, gender identity, disability, age, pregnancy, criminal record, marital status, genetic information, sexual orientation, veteran or military status, status as a victim or witness of domestic violence, weight, height, and/or any other protected class covered by federal, state, and/or local anti-discrimination laws. Join us as we continue on a path towards our destination of equity.
Very nice.
Very good.
Well, I'll ask Sally and Jackie for any comments. I wanted to note that Dr. Peñamora wrote in how much he appreciated the statement. Frida wrote in how much she appreciated the statement. Dr. Calamia wrote in how much he appreciated the statement, because the three of them knew they would not be here when it was read.
And I appreciate the statement very much. It's very much needed.
Okay, very good. All right. And we will now distribute, this will go out to all staff. We wanted to wait until it was heard here, but now we'll send it out to all staff.
Yes, good.
And I want to thank the board for their support.
Yes.
Okay. We will continue with the CMO report. While we have a number of ongoing clinical initiatives, we'd like to take this opportunity to update the board with our telestroke program. Dr. Bell?
Sure, yeah. Kalisha, do we have the other version?
This is the one.
Oh, there it is. Okay, got it. Perfect. So good morning, everyone. Donnie Bell, neurointerventional physician at Kings County, as well as System Deputy Chief Medical Officer, and we appreciate the opportunity to discuss some of our initiatives in medical and professional affairs that align with our strategic pillars of outcomes and quality. So next slide. All right, so the first of which is telestroke, and maybe if we could go back one slide, there are three initiatives we'd like to discuss. So the first is telestroke. The second is Viz.ai, and the third is System Stroke Certification. But before we continue, there should be a. Do you have another version, Kalisha? There's another version of the power. Yeah. Okay, we'll go with this. All right. So why telestroke? Next slide. So in November of 22, the Joint Commission was at Queens doing a stroke survey, and they noted that there were two levels of care for stroke patients, particularly on nights and weekends, that patients were cared for by ED physicians and neurologists over the phone. And although they did not get a citation for this observation, it was noted as an opportunity for improvement. The other why for telestroke at Queens Hospital is that they've had some challenges with recruitment and retention of neurologists. Recently, their stroke director left to pursue another opportunity, and prior to that, their previous chief of neurology passed away, unfortunately, to pancreatic cancer. So there was certainly an opportunity at Queens Hospital. The telestroke program there is composed of 9 credentialed neurologists who have subspecialty training in vascular and stroke neurology, and they represent all of our academic partners. It is a two-way audiovisual connection between the patient, a facilitator at Queens Hospital, and a neurologist who's functioning as a teleneurologist. And below are just a few of our key performance indicators. As you can see, by participating in this program, stroke volume has really been driven at Queens Hospital. In the first quarter of this year, they've seen over 200 stroke patients as compared to 170 in the entirety of the previous year. 55 of those patients were seen by our teleneurologist. They've administered or they've recommended TPA on 3 occasions, and they've transferred 6 patients to sister hospitals for higher levels of care. A few clinical vignettes here, or case examples. So we like to say in the stroke community that time is brain, and about 4 million neurons are lost every minute during an acute ischemic stroke. And so teleneurology has really driven significant improvements in time to treatment. In the first 3 examples, you can see that the time from the door to TPA was 43 minutes, which was the best time ever at Queens Hospital. The time from the door to out of the hospital for transfer to a higher level of care at another center was 57 minutes, which was also their best time ever. And these cases, again, we're working with teleneurologists, and that's roughly a 30% decrease in time to treatment or time to transfer. Next slide. So let's pivot to Viz.ai. So again, the mantra within the stroke community is that time is brain. And one of the challenges that we face in the stroke community is neuroradiology expertise. Not all of our hospitals have 24/7 access to neuroradiologists, so to be able to supplement with AI was important for our teams. Another important point is the ability to look at imaging mobilely. Some of our providers, particularly the subspecialists, are not in-house, and so the ability for them to review imaging and make decisions and mobilize teams for stroke care is important. And then lastly, it's a communication tool that enables interdisciplinary communication across different components of the stroke team, as well as systemness when we talk about transferring patients to higher levels of care. Next slide. So this is what the platform looks like. On the left, you see a real-time notification to a subspecialty provider that, hey, there's a stroke patient that might benefit from an intervention. And the next screenshot of the phone, that's the mobile image viewer. And on the left there, on the right side of the screen, you can see that there's an artery that appears blocked. The next phone screenshot is looking at advanced imaging that the platform has automated to try to estimate the amount of brain tissue that might be salvaged with an intervention. And then lastly, on the right, you see that the platform also enables interdisciplinary communication across the team members to help rapidly coordinate care.
You want to show, Donnie, just for the non-doctors?
Sure,
Because it's
yeah.
pretty easy once you see. See how the blood is going all the way here to the brain? So you should see the same thing on the other side. But you see you don't. The vessel's missing because there's a block here, right? So one of the great things about, the human body is in almost all cases, there are two sides, right? And so, and not 100%, but generally, two kidneys, two lungs, two ears. Generally, you can look at the body and see when there's a difference. And on this one, you should see the same as you see on the left, on the right, and you don't because there's no blood going to the brain.
So as you pointed out, the
clot right here.
right, okay, it's nothing there.
Is that you don't see the vessel?
You don't see the
way you
vessel
see it
going
here,
right.
because what lights up is the blood,
Right.
which has a dye in it to light up. But because it's a clot right here.
Now, do that cause nosebleeds? Because a lot of people suffer with do that come from the brain? I've often asked that. I mean, I've suffered through the years with them, but then a lot of children have nosebleed. Do that come from the brain?
Generally, nosebleed is one of those things that has many, many causes. So it can be anything from local trauma in the nose to people having very high blood pressures, and high blood pressures can be a cause of stroke, although that's the other kind of stroke. But I'm sure he'll show you, I've seen pictures of how Donnie himself and as well as his colleagues will remove that clot, and then the vessel looks just like the vessel on the other side, right? Because he's returned the blood to that part of the brain. It's absolutely amazing. Okay, Donnie, sorry to
How
interrupt.
do they take these pictures? The person is home.
No, person's there.
In the
Only the doctor is home
Okay.
at the moment.
Exactly.
Okay.
That's something. That is so interesting. That is something. Technology.
Yeah, so and the other thing I would emphasize on that slide is that all this happens with particularly the imaging part where the platform identifies the blockage and processes the advanced imaging without any intervention from anyone from the team or a radiologist. So this happens all in the background and says basically to everyone on the team, hey, take a close look at this patient. We think this is someone who could benefit from very rapid treatment.
Right, so Donnie could be at home and not able, say, to come in.
Wow.
He'll look at the film and then from home and he'll say, yes, this is a candidate where I think you can go in and get out the clot. Or he'll say, no, the vessel's too narrow, the vessel's too tortuous, that part of the brain is already, dead, right? So from anywhere in the world with his telephone, he can then tell you whether or not the person needs the procedure or not. When they need the procedure, obviously he or somebody will have to go and do it. We're not yet able to reach into your brain through the phone to remove the clot. That comes next week.
They're working on that.
Yes, I have no doubt they are. But for now, we're only interested in the idea
This is something.
that in general, as we're taking a bit of a commercial break. Part of why this is so important as a general trend in healthcare is because the more healthcare gets specialized, the harder it is to have every possible specialty in every possible place at every possible time. You just can't do it anymore, right? And so the only way you can continue to deliver the most advanced care at every moment is to allow virtual care. Because Donnie could be looking at an image one moment from South Brooklyn and the next moment NCB. even if he were willing to be on call, just the time it would take to go from one place to another would prohibit the kinds of things we're doing. But in one spot, he could be looking at images over that period of time. And that's, for things like primary care, where time is not so important usually, it's okay if the activities are done mostly in person. But for very specialized things, it will have to be something, because there just will never be enough people to guarantee. And that is a very different model than the traditional hospital, which is, here's the hospital, here's who's on staff, that's what you have to work with, right? And what we're really on the beginning of is being able to provide highly specialized care regardless of where the specialist is.
Yeah.
All right, Donnie, I'm sorry I interrupted you.
No worries, and that's the
That's
same
good.
thing
That's
we've
good.
seen with the teleneurology program as well, right? We have providers who are affiliated with all of our academic partners. They're spread throughout the city, and we're basically able to teleport them to Queens Hospital where they don't have those specialists. One of our facilities has published on using this AI platform to assist in the CT interpretations. That was South Brooklyn, and they noted that it decreased their door in, door out time. So the time from when a patient presents with an acute stroke, they need a higher level of care. So for instance, they may be transferred to Bellevue. That time has went from around 120 minutes to about 60 minutes, so almost a 50% decrease at South Brooklyn. Okay, and lastly, let's pivot to Joint Commission stroke certification. So back in 2018, which seems like many, many, many moons ago, the state decided to transition their stroke certification program from a state-based program to a program largely administered by third-party national accreditors such as the Joint Commission. And next slide. And so at that time, at Health and Hospitals, we only had 3 facilities that had Joint Commission certification. That was, let's go back one more. That was Lincoln as a primary center, Kings County as a primary center, and Elmhurst as a primary stroke center. And a few of those facilities were also performing some advanced stroke interventions at Kings, Bellevue, and Lincoln. Next slide. And at that time, we proposed that our future state should be this, essentially to summarize, our level 1 trauma centers would be thrombectomy capable stroke centers, so they would be able to treat patients like the ones we just reviewed. And our more community hospitals would be primary stroke centers. So that was our proposed future state back in 2019. Fast forward to 2023, and as you can see, those maps look largely the same. So we've been able to get almost all of our centers Joint Commission certified at 3 different levels: primary centers for most of our community hospitals, thrombectomy centers for most of our level 1 trauma centers, and then we have Bellevue as a comprehensive stroke center, given the complexity of stroke patients that they're able to take care of. And as you can see, we also have Viz.ai and Telestroke listed here. Next slide. Okay, so just to wrap up, future plans, we will be rolling out Telestroke at additional primary stroke centers at Health and Hospitals by Q4 of 2023. There are some additional modules in Viz.ai that we will explore, such as brain hemorrhage and aneurysms, to figure out if they will further help us to take great care of patients in a timely manner. And then lastly, there's one additional facility seeking Joint Commission stroke certification, and that should be completed by Q1 of 24. So thank you for your time.
Very good. Well, it's very exciting. They've saved a lot of a lot of neurons. I'm not sure before this presentation, Donnie, I even knew I had 4 million neurons, let alone that I could lose 4 million in just a minute. That's a lot of neurons to see.
Yes.
Sally, any questions?
No, terrific presentation.
Jackie, any questions?
no.
Okay, very good. All right, so, Michelle, have we done the whole medical report?
yes.
Okay, and we've done questions. Okay, then, very good. Dr. Shah, nice to see you. Thank you for sitting in today. We appreciate it.
Thank you, Dr. Katz. Good morning, everyone. Because of time, we probably won't get to the tail end of this deck, so I do want to just mention before we turn our mind to recertifications, to mention firstly that the MetroPlus HIV SNP, term Partnership in Care, learned earlier this year, a month ago, that for measurement year 2021, which is the latest year for which data is available, compiled by New York State, the SNP was the highest ranked SNP in the state. I think it's a testament to the work of the HIV SNP, but also our strong collaboration with our HIV primary care providers, many of them at New York City Health and Hospitals. We achieved the highest viral load suppression rate amongst the 3 SNPs. It's not the only indicator by which the SNPs are judged. Obviously, as the population ages, over 50% of the people living with HIV now over the age of 50, there are a lot of measures related to controlling high blood pressure, diabetes, but on the central measure, which is viral load suppression, we were highest ranked for measurement year 2021, which is the latest, again, for which data is available. On another note, in the second quarter of 2023, the MetroPlus Health Housing Task Force housed its 500th member, and that's again, a robust partnership with many CBOs, individuals and coalitions that focus on housing, including working strongly, again, with New York City Health and Hospitals on its housing initiatives. So I did want to turn then to the main item, which is recertifications. As many of you are aware, the public health emergency, once it ended in April of 2023, the state did determine, along with many other states, that it would require individuals enrolled in Medicaid, which includes, by the way, the HIV special needs members, individuals enrolled in the health and recovery plan. Those are the individuals with serious mental illness or substance use disorders, as well as individuals in the essential plan and Child Health Plus, to redetermine or recertify their status based on income levels and other requirements. To that end, the first month by which individuals had to recertify based on their due date was the month of June of 2023. We worked closely with community providers, community-based organizations. We're principally with colleagues within MetroPlus to outreach the 45,000 or so members who needed to recertify or redetermine themselves in the month of June. That process began in the middle of May, when the recertification window opened for these individuals. Always starts the month before. And the date by which they have to recertify is the middle of the month in an ideal state, so that they can be active for the first of the following month. That's the 45 days which are available to these individuals. The principal modality by which we've done our outreach is telephonic, talking to these individuals, making them understand what the forms that they've received from New York State, they may have not fully appreciated what was involved or what to do with them, lead them through that process. But we've also been working closely through texting and email campaigns, as well as working very closely with hospital health systems like H&H, but also community providers, where a very large proportion of the MetroPlus members have their membership, to ensure that these providers are also fully aware of the ramifications of the failure to redetermine or recertify. Next slide, please. We completed in that effort town halls with many, again, community-based organizations, including town halls at all the H&H acute facilities. We created a very robust recertification dashboard that can be tracked on a daily basis. And our customer experience team, CSX leadership, is continuing to work with community providers and H&H facilities and managed care teams to ensure that they're also fully aware of what needs to be done, working with the financial counselors and the certified application counselors to ensure that members recertify on-site or over the phone or in the community at our community offices to maximize the individuals who don't lose their coverage, their medical coverage. The last item there is an innovative tool which allows an individual to schedule time at their own convenience to recertify. They can book an appointment with our recertification team to ensure that individuals appropriately engage with us at the time that's most convenient to them and complete the appropriate paperwork. Next slide, please. So the number for June was, I said, about 45 to 46,000 members. That number moves a little bit depending on the data that's available from New York State and HRA, the Human Resources Administration. And you will see at the top that approximately 28, and at this point 29,000 individuals, or close to 65%, have actually recertified, which then leaves 15,000 individuals, the 35%, who have not recertified. Of these individuals, of the 15,000, we know that 8,000 actually on a file, a termination file, produced by New York State and HRA to tell them that they have actually will lose their Medicaid, have lost their Medicaid coverage as of the end of June. I'll say a little bit more about the window period that's available to them, but that's 8,000. There remains around 7,000 individuals who are not on that file and whose status remains unknown and therefore essentially salvageable. Why is it unknown? It's because it's an evolving understanding of who these individuals are. They're not on the term file, but they're not active either. So they're in this unknown status. And that's the status we're also driving to understand, working with New York State, working with HRA to ensure that those individuals, if they are able to be salvaged in terms of for that month of June, that we'll do so. But that's our goal here, to have, again, a better understanding of that 7,000. I would point out since you mentioned the HIV SNP on the right-hand side, you'll notice the health and recovery plan, which are individuals with serious mental illness, and the HIV SNP with much lower rates of recertification. The reason for that is that these individuals have disproportionately have SSI coverage, and their recertification process is different. As long as they re-up their SSI, which occurs roughly every 3 years or so, their Medicaid will remain active. Those individuals' recertification dates is not visible to the plans of yet, but to ensure that many of those individuals will retain their Medicaid status. And again, that's why it's just proportionally low, because they have actually a high number of SSI coverage in addition to their Medicaid. Next slide, please. This just to show that I mentioned the whole notion of people going to book their appointments, and that process has been, I think, well received. 818 appointments have been scheduled. Next slide, please. We've also expanded our concierge program at all the acute sites and many of the Gotham sites. Harlem will be active next month in August. But just to assure people, the concierge mechanism is not the sole mechanism. In fact, it's a minority mechanism of how people redetermine themselves. The major mechanism is our telephonic outreach, our connection with providers to ensure that they are identifying individuals who are coming in for recertification, and their providers contacting us, including our goal is to be placing ourselves in the community providers' offices to make outbound phone calls within their offices to help individuals recertify from a number that they recognize as their own, meaning the provider's office, not an office phone call coming from MetroPlus. Next slide, please. And this is just to alert everyone once again about the window period. So people had for June, with the coverage end date ending at the end of June, June 30th, the timely renewal period was from the middle of May to the middle of June. They then have another 15 days in June. As long as they recertify within those 15 days or an additional month in July, those individuals, despite losing their coverage ostensibly at the end of June, will be reinstated to the beginning of June 1st. We're not complacent that we have all of July to do this. Our goal is to be more proactive than retroactive in terms of these efforts, but just to assure the board that there are still ongoing efforts for the remainder of July to bring those June members back into the coverage should they qualify based on their income level. Happy to take any questions.
Questions from the board?
I just want to say, it's just been an extraordinary effort between H&H and MetroPlus to get these 60,000 members recertified. And it was additionally burdened, I think, by the challenges of dealing with the state NHRA. We just weren't in lockstep all the time, so it created additional time pressures and because we needed approvals before we could do things, and yet you are at 65%. That's amazing compared to other states. We are light years ahead.
And we spoke, Sally, thank you. We spoke with New York State just to make sure we're on track. We had a conversation with them. They were pleased with the progress the plan has made. It's consistent with the work of other plans. And they acknowledged, to your point, the issue of the unknowns and how they have to get better at informing us about the unknowns and their status to ensure that they're not unnecessarily, we don't be over optimistic about the numbers or pessimistic, but we want to be in the right place knowing that individual status.
Very good. Okay, well, thank you, Dr. Shah. And I want to also just note that Dr. Shah not only has administrative responsibilities, but is himself a provider in the HIV clinic and thereby shares the success of being the #1 HIV clinic in the state. So with that, your chief nursing report is a written submission. Is there any old business, any new business? And there being no further discussion, our meeting is adjourned with a minute to spare. Thank you all.